Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon. I'm the chair and organizer of Grand Rounds. Thank you very much for your patience, those of you who have been waiting in the virtual room whilst we just got over a few technical difficulties. We got there in the end. So I was just talking to Pascal, one of our speakers today, before as we were warming up, and we've been doing Grand Rounds in this format for 8 years now, and I figure it a success that we're still here and still having talks. But one of the core sort of principles for me was that Grand Rounds is for everybody, and it's to try to pull together Dundee University Medical School and the wider university, along with NHS Tayside, the primary and secondary care, the HSCPs, the medical students, allied, not just doctors, professionals allied to medicine, everybody. So we don't often see our primary care colleagues, and as Pascal points out, it's not the ideal time, 1 till 2, when people are on home visits and starting their afternoon clinics. But it's a really important thing that we do involve everybody. And so I'm really pleased to welcome the pharmacy teams and prescribing in primary care general practice team I'm going to start off with Jill Lowell, who's going to talk about, she's the Associate Director of Pharmacy. She's going to, I think, introduce things. And then Pascal, who was here only a few weeks ago, and he's even asked for another talk for a couple of months' time. So he's becoming a regular. And then Michelle Logan is the lead pharmacist out in Angus. And they're going to talk about the work that has been going on in terms of improving, streamlining, and prescribing and the links between primary and secondary care. So I shall duck out now and leave you, I think, with Jill in the first instance. If you have any questions, please put them in the chat and we'll get to them at the end. Make sure you're muted, and thanks very much.
No, that's brilliant. Thanks very much, Tom, for that introduction. So yeah, absolutely, as Tom says, we're going to do a shared session this afternoon. So I'm shortly going to pass to Pascal, who's going to outline, first of all, just in a few slides, a bit about the current GP contract and what it's aspiring to achieve. Then Michelle and I are going to present the second part of the session, which is a bit about looking at one of the elements of the GP contract, the pharmacotherapy service, and what that entails and what's different from the previous pharmacy service that we've been providing into general practice. And then the end of the session is going to come back to Pascal, where he's going to describe some of the policy and processes for prescribing between secondary and primary care, and he's going to take us through some examples of where prescribing could be improved. So hopefully it'll be clear once you've heard the context of how medicine's activities have changed within general practice with the advent of the pharmacotherapy service. So first of all, I'm going to pass over to Pascal.
Thanks, Jill. So let's have the first slide. I'm grateful to my colleague, Andrew Thompson, who, these are his slides. Next one, Jill. Next slide, please. Yeah. Okay. The first point I need to make to you all is some of you will have GP friends, family, partners, and so forth, and you'll be aware of this. But many people out there, if you've no connection with GPs, won't understand the concept of the 2018 contract. So between 2010 and 2015, general practice and GP stuff went right downhill. And I mean really downhill. Now, there's pressures on every parts of the service at the moment, but even then, all the signs were there. We couldn't recruit, workload was up, and we were in a crisis. Up till then, we shared the same contract as everybody else across the UK. So it was a national British contract. And although we could tweak a few bits in Scotland, we used to call that tartanization of the contract, we were on our knees. So our representatives and members of the Scottish government went around Scotland, big meetings, got the GPs in, to whom they listened to and heard the impassioned pleas for help that we were in a really bad way. Now that was 2015. So for 2 years, nothing changed. The contract was developed and then it went out to be voted on, and it was voted on early 2018 and was approved. And so that became the contract, and it was meant to be implemented in 3 years. So it should have been done and dusted by April 2021. Down across here are the issues that we were having. Next slide, please, Jill. And one of those factors, and I'm not going to go through all the other bits, was this issue about the workload of providing prescriptions that traditionally went back to 1948 and probably was fine then, but absolutely wasn't in 2018. So pharmacotherapy was one of the parts of the contract. And the idea is we would have pharmacy-based services that would be expanded, and Jill and Michelle are going to talk about that. But the key concept is, and it's going to come into law at the beginning of April, is that the responsibility for these, and we're pinning down which prescriptions and so forth, it falls to the health and social care partnerships. So like legislation was passed to say that from such and such a date, it's the responsibility shifted to the health and social care partnerships. And many of my colleagues, and yourselves included, won't be made aware of that. It's not something that's on the news. So they'd be surprised to say, well, but I sent it to the GP. Why didn't the GP do something, or, you know, do what I asked? And this is why, because of this. And the other, so there's a similar thing, for example, vaccinations, for those of you who don't know, they were transferred to the health and social care partnerships last April. And as I say, we're 2 years behind and the contract is not implemented. I think we were on our knees then, and now we're on our backs. So the future of general practice in Scotland is what is at stake across the various areas that we need to improve to get GPs and get general practice working. Jill, next slide. So I'm not going to dwell on this one. It's about teamwork, or do you stay in the practice? Do you work in the hubs? Again, Jill. Next one, Jill. But the goal is to get to a place where the incoming requests are done efficiently, done safely, and with the patient at the center. Next one, Jill. How will we know? Well, we're not there yet. We'll know these things down here when we have happy teams. We are down 7, I don't know if you're covering this, Jill, but we're down 7 clinical pharmacists in the Dundee area. We had a few more, but one of the reasons they left was the nature of the work they were being involved in. And the reason they got caught up with that was because of it wasn't an efficient way, and we hadn't got the word out properly and successfully to our colleagues. But we feel we're getting there and a lot closer now. And this presentation today is one of a series of things we're doing to get the message out. Last one, Jill, I think it's over to, yeah. But one of the things when I talk to my colleagues, both in primary care, secondary care, and anywhere, is it is a change, right? So this is not a case of a variation on what went before. This is transformational. And I'm very open to encourage creative thinking and being innovative. I took on some work about a year ago, a couple of sessions a month, to delve deeper into how to improve these things. And the people out there who's listening that I've worked with will know that I've listened to what the issues are on the other sides and on primary care, and we've had good success, which I'll come to later on in the presentation. That's it, Jill, I think. It's over to you.
Yeah, no, thanks for that, Pascal. So Pascal set out there what the new GP contract is aspiring to achieve. And I'm just going to spend a little bit of time just going into a little bit more detail on the pharmacotherapy part of that service. So in 2021, we got a revised GP contract expectation through the Memorandum of Understanding too. And that helped us with some clarification around what was expected from pharmacotherapy. So it's basically broken down into three levels, and the first level is medicines management activities. So I'm not going to read out what's on the slide, but you can see there that the asks is that pharmacy teams help with managing acute and repeat prescriptions and medicines reconciliation. But the key point from this slide for me, which will help with the rest of the conversation today, is that we're trying to principally deliver these level 1 medicines management services by our other professional group, the pharmacy technicians, supported by pharmacy support workers and administration staff where appropriate. So I think that's an important point to make. The next important point that came through with MOU2 is around the higher level, the level 2 and 3 services. And this is primarily setting out expectations around what we expect the roles of our pharmacists working in general practice should be. So we want them to be working on high-risk medicines and high-risk patients, so undertaking regular medication and polypharmacy reviews and really delivering that direct patient-facing clinical care to patients. So I think Pascal alluded to this earlier. We had an existing GP practice pharmacy service in place prior to April 2018. In fact, in some respects, Tayside was one of the leading health boards in Scotland, and we've got over 25 years experience of introducing pharmacists working directly in general practice. Our pharmacists had a dual role. They were providing that direct clinical care and undertaking polypharmacy reviews, and they also had that prescribing advisor role as well, undertaking audit and review of prescriptions and working to improve prescribing within general practice. So with the contract came some funds from Scottish Government, I guess. So there's been some significant investment in primary care services through the Primary Care Improvement Fund. And we've been successful within the pharmacy service at bidding and receiving some of those monies to improve and increase our workforce. But I think what, again, I'm trying to tell you from this graph here is, so we had an existing pharmacy service, and then we have managed to increase our workforce. So you will see we have increased the number of pharmacists we have working within the service. I think, as Pascal alluded to there, that has plateaued significantly over the last couple of years. And we have lost some pharmacists, and we've reached a stage where there, I guess a lot of you will know from other parts of the service as well, is that there's significant recruitment challenges in the number of pharmacists that are available to come and work in any one place. So what we have done is we've significantly increased the number of pharmacy technicians working in general practice. And we've also managed, of just the last couple of years, to introduce new roles into the service as well, predominantly through pharmacy assistants, so our support worker roles. So I'm going to hand over to Michelle now, who's going to take us through how we've had to work differently since this investment's come into the service and there's been new expectations placed upon us.
Thanks, Jill. So Jill's just described to you more of what we've been doing in the last few months, the MOU2, but I want to go back a few steps now to try and describe to you how we approached the delivery of this pharmacy service following the introduction of the contract in 2018. So in preparation for the service delivery, we undertook a 12-week test of change in about 6 practices across the whole of Tayside, and we tried to focus on intensive delivery of the activities that are outlined predominantly in the level 1 section, which, as Bill's mentioned, is medicines reconciliation of all the discharge prescriptions, all the communications from outpatient clinics, looking at repeat and acute requests from patients, and undertaking proactive medicines review. So once we did the test of change, there were quite a lot of meetings to discuss what we thought was feasible from a capacity point of view for the teams to undertake on a regular basis. So we looked at the service, took account of the workforce that we had available, and then in consultation with our GP colleagues, we decided that the pharmacy service at that point would focus on medicines reconciliation of the hospital discharge prescriptions and the outpatient communications from secondary care, and that would be it from that level 1 part of the contract. So we parked things like acute requests and repeat requests at that point. So all of the communications that are workflowed into the GP practice now all come to the pharmacy team. So all of the things that come from discharge prescriptions and outpatient comms are actioned, all changes, by the pharmacy team in the main without consultation with the GP, unless that is absolutely necessary. Next slide, please, Jill. again, as Gilles mentioned, prior to the contract, there had been pharmacists present in all these practices to some degree, but the investment that you've seen has allowed us to employ technician colleagues to work with us towards this goal of delivering this contract. And looking at the numbers on Gilles' graph, you would think that looks really good. We've really increased our workforce greatly. But unfortunately, despite all that investment, it became clear quite quickly that although there were more staff in place, the model wasn't quite correct, and this has led to evolution of the service. Next slide, please, Jill. So some of the reasons behind the evolving service delivery model that we have are they're multifactorial. So we've had to include the staffing that are available to deliver the volume of work that's coming through, the space available within GP practices. So in most of the practices across Tayside, even if we were able to recruit the number of staff that we need to provide the service, there simply wouldn't be the office space, the desk space to accommodate them within the practices. We've also got to take into account our geography. Two of the health and social care partnerships in Tayside have got vast geography and vast distances to cover. So in terms of staff who maybe covered more than one practice in their week, travelling between the sites to try and deliver some of this service would have been counterproductive. There would have just been too much time spent travelling between sites, and we would lose huge chunks of time throughout the day, because it was quite clear that service delivery that we needed to deliver every day. We couldn't do it once or twice a week, so we were going to have to travel if we were going to accomplish that. So that's been definitely a bit of a reason for evolving the service. And I think finally, and most importantly from this, it's the actual volume of the medicines reconciliation work that's coming through, and it's increased to a point that it just became clear that to try to provide it with the pharmacy teams that we had, we're giving them still capacity to undertake that level 2 and 3 work that Jill described, to allow for cover during holiday periods or sick leave, and to ensure that we as a service maintain job satisfaction for the whole team, that we were going to have to look at a different model of service delivery. Next slide, please, Jill. So this is where the current hub model that we're now running comes in. So about sort of 2019, mid-2019 time, I think, we were having discussions with other health board pharmacy teams to see how they were approaching delivery of the contract. So that led to lots of other work being carried out. Now, initially we did it in Angus. That top picture in the left-hand corner is where the pharmacy department in Stracathro is. So what we decided to do was we would trial a pharmacotherapy hub sited in that existing pharmacy department in Stracathro. Initially, what we did was we manned it just in the morning with one pharmacist and one pharmacy technician, and it worked relatively well. Everyone took a turn, they did it on rotation, and I suppose it's just sort of snowballed from there, so that now, 4 years on, almost 4 years on, there's 6 pharmacotherapy hubs in multiple locations across Tayside. So there's some in Dundee, there's some in more in Angus, there's 1 or 2 in Perth and Kinross now as well. We've tried to optimise that staffing model that we've got in there, and as Gilles described, we've more recently taken on pharmacotherapy assistants, and they've predominantly come from stolen, I suppose, from GP admin staff and maybe GP receptionists or counter assistants in community pharmacy. So they do have a bit of a healthcare background. And I think it's important to understand the different roles of all these people in the team now. So the model runs kind of like a triage. So the assistants, the pharmacotherapy assistants, will deal with any non-medicines requests that come in from outpatient clinics. So things that maybe come from dietitians, supplements or emollients and creams that are quite basic, catheter products, stoma products. They're the ones that will process all of them without it coming to a technician or a pharmacist. They also deal with medicines reconciliation of some of the discharge prescriptions. So again, if we've got what looks like relatively straightforward and simple discharge prescriptions, so things like a surgical prescription from ophthalmology, where it's just going to be a short 4-week course of some eye drops that don't need to get put onto the patient's repeat record, the pharmacotherapy assistants will deal with that. They'll deal with things like just simple pain relief, maybe from outpatient or not outpatient, day case sort of surgery, like vasectomies, hemorrhoid work, that kind of thing. They'll deal with all of that. They're also responsible for double checking and filing any final discharges, because we quite often will get an initial discharge prescription in and then we get a final, and we have to look at them to make sure there's no discrepancies. So again, the pharmacotherapy assistants are in charge of doing all that. So if it's a final discharge with no changes, they will just get rid of it. If there are anything that they see as a discrepancy, then they'll flag it to either a pharmacy technician or a pharmacist, depending on the nature of the change that they see. So that's kind of what they're doing, as well as providing us with some key organisation of the way we run our hubs. The second staff group that's working in the hub are the pharmacy technicians, and they work independently. Again, in terms of they deal with discharge prescriptions or outpatient communications, they deal with it to the level that they're comfortable with. But again, if there are any issues that are out with their scope of practice or that seem particularly complex, then they will flag them to the pharmacist that's on duty. And then we have our pharmacist team that's in these hubs. Now, again, like with all professions, the pharmacists that work in the hubs have varying levels of experience, varying amounts of years worked. Some are independent prescribers, some are not independent prescribers. And I think that does introduce a little bit of variation, probably in terms of what you will see in secondary care in terms of the communication that you might get. So you may well have communication about an outpatient letter that you've written from a pharmacist, a junior pharmacist, or a technician. And I think it's quite important to have that level of understanding about who's going to be asking you questions, I suppose, about what you might have sent through to primary care. I think the staffing model we have, it's key that all that work comes in a very clear way, just because of the different staff we've got and the volume of work we're doing. So to try and put it into perspective, just one hub out of these 6 on average will deal with about 1,200 discharge prescriptions a month, nearly 1,500 outpatient communications, and they phone approximately 1,800 patients a month as well. So this is huge volumes we're talking about here. So if anything comes in that's sort of ambiguous, then it will just cause delays to processing the work, and then I suppose ultimately to the care of the patient. So that's why it's key that everything that we get is really clear and unambiguous. Can I have my next slide, please, Jill? So I suppose that brings me to what you could describe then as our current challenges in describing all this huge volume of work. We're still running with insufficient staff to deliver the service, and as Jill's alluded to, and particularly we're plateaued with pharmacists, so we're unable to recruit them at the moment. There's a strong focus on trying to get these practice processes that are in place right. I mean, it's been a big change for the practices teams as well, having to direct these workflows to pharmacists and pharmacy technicians, and they never did that before. So we're still ongoing working on optimising these processes, and there's still some grey areas about who delivers what within the practices. I think as we go forward with the MOU2 that Jill's outlined, the aspiration is that these pharmacotherapy hubs become what we're terming pharmacist light, so that we cannot give the pharmacists the opportunities to develop in their clinical practice, take on more advanced work to deliver level 2 and 3 of the contract, which when there is a huge volume of the level 1 work coming in, that can be quite challenging. And I think to operationalise all of this, we need to make sure that we've got opportunities for appropriate training for all of the staff involved, and I think that will hopefully help with our recruitment and retention and our ability to deliver this contract. But again, where can't say it enough is where we need your support is to make sure that what we're getting into the workflow in these hubs is easily actionable by all the hub staff. And I think that is quite key again to us moving forward with taking on other aspects of the level 1 bits of the contract, like acute prescribing, like repeat prescribing, that we're just not quite there with yet. So that would be my plea, but I'll hand over now to Pascal, I think, to give you a bit more detail on how you can maybe help us with some of this stuff.
Now, thanks, Michelle and Jill. So hello again. I love the spelling mistake, Scanlan. I better introduce myself better in case there's people here. So my name is Pascal Scanlan, and I came to be a GP in Dundee in the last century, 1994. And as they say, the past is a foreign country. we did things different then. But over the years, I became involved with pharmacy. I joined the GP subcommittee, and in that role, I joined the area drugs and therapeutics committee more than 12 years ago. And then I was on the medicines policy group. I mention that because I was saying how in 2015 things were really difficult. One of the issues that was difficult was the pharmacy stuff. And all the issues Michelle and Jill have mentioned there about the difficulty in processing communications from our colleagues in secondary care and other clinics was falling on the GP. So this policy document was written. I wrote it with Claire O'Brien, which is to say really Claire wrote most of it and I added a little bit here and there. But please note that it's April 2017 that it first came out. That's important because the presentation and the stuff I go through isn't just about the electronic communication form on clinical portal. It's about the principles that sit under good prescribing between secondary and primary care. And this document was based, stuff was lifted from other guidance documents that are, of course, already existed about good prescribing. I would also like to say that it has been changed. We are very open on our side, well, I won't say very open, but we are open on our side of the fence to dealing with things that arise that we didn't expect. So one of the first things that became apparent was that not all forms of prescribing do fit the electronic communication and the use of the boxes. And so we've met with various departments where exceptions have been made. And now the current document says the exceptions are, say, DMARD medication, complex titrations, such as in epilepsy. And if anybody feels that they have a case why the electronic thing isn't good for them, if they could please just get in touch with me. Those who have worked with me know I am approachable. Pascal Scanlan at nhs.net. Now, 2 weeks from now, I'm dropping out of GP sub LMC work and devoting more time to this pharmacy work. So please, I've been in contact with various people and I'd like to drive it forward over the next year. The other thing, yes, it's been updated in 2021, so I'm going to hold off for a couple of months before changing anything to deal with the issues that are arising out of this piece of work. Now, at the time, we were told it was going to be sent to every clinician in NHS Tayside, and it would be integrated into that. What I can say is that it's on public display. All you have to do is go to StaffNet, our website, pharmacy, medicine governance, policies, and I think we're second from the bottom. So it's not actually, I still meet plenty of people who've never heard of it. And I'm not going to go through it. Can you put up the next slide, please, Jill? So I'm not going through this page by page, but I would draw your attention to a couple of things. It sets out the general principles about clarity, accuracy, avoid ambiguity, make sure you've spoken to the patient about it, stuff like that. And it also explains to our secondary care colleagues what to do if you want to prescribe a non-formulary medicine, or if there's a new medicine out and you want to get it on Tayside area formulary. So this is the document to improve, which will guide you. Now, these documents are in other places as well, and some of you may be well familiar with the process, having done it in the past. But a phone call to a GP used to be a way, and it's just the truth, it was a way to circumvent some of this work. So a professional to professional conversation with my colleague seemed to get the patient the medication. So fine, that's good, but actually no in the long run. And now that our pharmacy colleagues are becoming involved in this, they are highlighting stuff, well, they are bringing to the surface other practices that have been going on for years and that are not actually that good, or we're not that good. Okay, next slide, please. So one thing I also want to emphasize is this benefit for the organization from the work that we've been doing. And these first two are just an example, and there's a couple of others. But at the beginning, the way it would work is I worked with just one cluster at the start, and they would collect and copy out, they print out the examples of the stuff that was causing them problems. I'd collect this stuff and then do an analysis of and looking for patterns and looking for things that I could fix. What became apparent after a couple of weeks is that you had doctors, prescribers, they could be non-medical prescribers, who were getting this screen without the boxes across the bottom. And then next one. This individual was not a prescriber. This was a nurse, and they had access to the boxes. And so going forwards, I informed people they had the wrong screen. They contacted IT, and then IT said, well, we can fix that. But when I got up to about 30 or 40, I felt this is more embedded than the odd case here and there. So I got in touch with IT, engaged with, I think it's a group called SAM, Service Access Management. They'd ran an analysis and found actually, yeah, it was much more widespread. And initially their thoughts were, well, that shouldn't happen. We've got safeguards here. That simply should not happen. That then led to another meeting with the people who know more about this than I do. And then they wrote a document, an SBAR, to go up the line to the executive level 10. And then many of you may have noticed, I think it was last October, November, there was a notice from saying that on such and such a date, they would unload and offload everybody and then instigate the safeguards to stop it happening again. And that has greatly improved the efficiency in the hubs, but it's also greatly improved the governance and the care, you know, the legal governance of prescribing issues in Tayside. As I say, there were a couple of other things, and I do think it's very useful to have access to what's going on at the coalface. So if GPs or somebody comes back with something, as well as saying, oh, I'll fix that, try and see if there's an underlying, I tried to see if there's an underlying system error, and then it can be fixed across Tayside rather than for just one clinician. Jill, please, thank you. So, all right, just some examples of what came into the hub, okay? And for everyone, there's another 40, 50, okay? There's just loads. So let me comment about this form. This is the outpatient communication form, often referred to as the ensemble, because in the practices, it comes up under ensemble, but that's just the name of the software that delivers it. And going forwards, we'd like to try and improve the language around this. And so I'm going to refer to it as the Outpatient Immediate Communication, or OPEC. It has limits, absolutely, but we've listened to and written down all the problems clinicians are having with it, engaged with, again, IT, and I believe found out recently that the new version of Clinical Portal coming out later this year, some of this stuff should be fixed. So just to identify some of the problems. As you put in your medications, I'm told that if you go backwards, sometimes everything disappears, which must be incredibly frustrating. And we'll try and fix that. This bit here, you don't actually see on your screen, but it shows up in the GP practice. It goes back to the days when everybody was seen face-to-face pretty much. So the patient was reviewed today, could be implied to say that whoever sent the document has spoken with the patient. But with the onset of COVID and the increased use of near me and virtual and asymmetric consultation, this phrase is not suitable and needs to come away. Our ask would be that under comments and recommendations, if you could just use simple English to say, I had a telephone conversation with this patient, or spoke on telephone, or, and we'll come to nothing, or saw face-to-face, or, and this is the important bit, have received a result, something like that. And I'll explain why that's really important. That's what it says, provisional diagnosis. There is no diagnosis. When we put the medication on the software systems in the practices on Vision, it has to be linked to a diagnosis. So this example is, it says that don't have a diagnosis, and our ask would be, could you put it in there, please? The frequency, the indication, and the duration. Duration, again, very important. Is this for repeat? Is this for a week, 2 weeks? All right. So this is what then generated the inefficiencies of the staff trying to figure out what do we do here. Next one, please. I just picked out a handful, and there might be a theme in it, but it was only because I looked for examples in the bundle of that department that I was working on. But as I say, it's across the board. And here's another one. Start that. No diagnosis. The tech, I mean, many of the clinicians on board will know what the underlying condition is here, probably, but the techs can't know that. So they can't put it on and link it. And again, how long is this for? Right. Thank you. Next one. Now, and then this is the kind of example that just flows through. This person is a prescriber. They put in what they want. Everything's there, and planned review at home. Now, the form no longer is only for prescriptions. So some areas are using it as a record, an electronic record of what they did on that occasion. It's the clinical record. So that there's a bit of that here. So this is not only for the practice and the practice record, it's also for either the same individual when they review this patient, or perhaps one of their colleagues will want to know this stuff, and they don't have to go off and do a separate, dictate a separate letter. And that's something we can talk about later on, if that's of help to some departments. That's been a great help. Okay, so that's the kind of thing. Now, I was saying about blood results. One of the big issues that has been problematic, Michelle was saying the number of phone calls they make. I think you said 1,800. Okay, so they generally phone to confirm everything's okay, or they have some kind of query around the information they've been given, or they're safety netting, which is to say, they're just checking, make sure everything's okay. But actually, done properly and done the way we talked about in the document, the clinician should have seen the patients, or at least talked to the patient, virtually or otherwise, tell them what they're doing, and instruct them to collect the prescription, which they've talked them through, at the usual place in 7 days, allowing 2 days for the weekend. And then when it comes into the practice, it gets processed, signed, and sent off. End of story. But as you can see here, they're calling people up, and then the people don't even know about this stuff. And so I checked in with some colleagues to say, like, how would that arise? And essentially what it is, it was blood result management. So they'd seen the patient, ordered some bloods, got the results, and then made this. Now, and here's the thing I'd just say, it's not that they were not interested in sharing this information with the patient. They might have dictated a letter, and in the letter it will say, I've written to your practice to issue the prescription. But because of letter delays, the staff are talking to, the pharmacy teams are talking to the patient before the letter arrives. So again, if that's a common thing in a department, perhaps we could have a conversation, please, on how to sort that out, okay, and find solutions so that, like, here's 3 people, okay, on one occasion. Thank you. I don't mean to be coming across as negative about stuff or demonstration, but this is what I would consider to be an unexpected outcome from somebody who was doing exactly what they thought was right. So I did this, got the results, made a decision, wrote to the patient, and asked the practice to issue without realizing this could happen. Next one, Joe. And that one was about changing a dose of thyroxine, but on occasion, the teams have run into bigger issues. And this one, for example, a patient was phoned up and didn't know they'd had an infarct. So they'd left the hospital and being told, it doesn't look like it, but we're awaiting the results of you'll get an MRI or something. So the MRI gets done, comes back, and it is, and medication is started. And I can understand if our colleagues thought, well, that'll go to a GP who might even look up the MRI, and it'll be the GP informing the patient of the outcome of the MRI. But under this new model, that's not the case. And I'd ask colleagues to keep it in mind. And again, please get in touch and I can map out ways, because I've already done it for some departments, on how to avoid this kind of thing. Next one, please, Jill. Right. This applies to every department and everybody. Since 2017, when that document was written as a policy, went through all the appropriate levels of approval, medicines policy group, area drugs and therapeutics, right up to the health board meeting where it was praised and said, oh, this is a really good thing. It says quite clearly that it's the clinician's responsibility to provide the medication if it's needed in the first 5 days. And as Jill was explaining earlier, that is the rule, that's what should happen. But on the rare occasion though, when a clinician finds himself in, I really need to get this medication to a patient, and for in that situation, they feel that the way their system is set up that they cannot do it, sending this electronic to the practice, and on this occasion it says, I phoned him and told him to expect an urgent script. That then triggers a phone call to the practice where they have to search around to find this document and then find who's going to deal with it. And that isn't part of the pharmacy team's remit. And there are solutions, okay? There are absolutely definite solutions. So this should not need to happen. Next one, please. I couldn't help picking this one, sorry, but this came at 2:30 the day before Christmas Eve. And here's the safety issue. It's not about the fact that, you know, asking the practice to do it. The point is, in many, many practices, this would not have been seen for 4 days minimum. Okay, so it's in the afternoon, they'll have done their doc flow management, they'll be back in on Monday to look at the, you know, whatever's come in since. So there's every possibility that patient would not have got the treatment. It doesn't say here whether the patient was told to call, but the person I spoke to said, well, they'd just like to skim down through what was in the thing before they went home to make sure there was nothing important. And this is what they came across. But that was safety netting by a colleague, a pharmacy colleague who just wanted to rest easy going home for Christmas. And indeed, as it says there, they passed it to the GP, who I'm sure was thinking, oh Lordy, we've got 2 hours to sort, well, maybe not 2 hours, because we have late opening pharmacists till about 8 o'clock in Dundee. Next one, please. Right, this isn't 100% clear, and as you can see, I improvised with cover. One of the things that arose after the document came out in 2017 was this issue of requesting medications in letters. The initial document said it is the expectation that all requests would come electronically. This was then modified to say we would expect them to come electronically for the majority, except for these following exceptions: DMARD, complex titrations, multiple medications. So like our dermatology colleagues, if you can get it out quickly and you've got 7 creams to put down for 5 different parts of the body, totally get that. The electronic boxes thing would drive you nuts. But this was this is the kind of thing that comes to an SEA, as we call them, significant event, or you have a phrase for it on your side. What I want you to notice that the patient was seen on the, but it's so small now, even I can't see. The clinic date was in August, the 27th of August. The letter was typed the 26th of October. And this involved a locum coming in who wasn't aware of these things and just dictated the letter. And it involved significant medication changes to do with the patient's condition. And they didn't get that change for a long time, a long time. And finally it was picked up and people realized. Also, not every practice is going to check every letter to make sure every one of those that says started a medication, to make sure it came in electronically. That kind of workload safety netting we just can't do. And knowing what the agreement is, some practices may read every letter. Some practices may read some letters, and it is possible that some practices will file letters in the belief that, well, somebody's going to read that letter when we next have contact with the patient. And a bit like in outpatients, like when you get letters and the next doctor who sees the patient reads what happened last time. So there is a genuine safety issue. I don't know who's on this call, but I raised this issue about locums and this risk at important levels of where people I thought would be open to the idea, but got told, well, sometimes locums are only here for a day or so. All right, I would ask that every department would look to see that every locum, somebody should be responsible for seeing that every locum knows about the risks we're highlighting today. I initially started by going to departments and trying to find who was in charge of induction, ask them how they did it, and then individually try to draw this to their attention. I have had the opportunity, and I'm grateful for it, to present to the STs and the FYs at their inductions the last 3 years, but I'm finishing with the GP sub. So I'm hoping that invitation will continue to my replacement, but I wouldn't cover consultants and so forth. So if anybody listening is thinking, I wonder what we're doing in our department, please keep that in mind. This is a serious thing, and people have come to harm because of the individual not being made aware of these difficulties. Next, please. I was saying earlier how it's useful to have someone like in this role that I fill to get the feedback so they can pick up on oddities, and I'm just going to call them oddities that arise that nobody would have been aware of. This is an example of something I saw day after day, every day, multiple 10 years ago. And this is the old paper form for patient discharge to take home with them. From memory, I think there were 3. One went in the record, one was given to the patient to hand into the GP, and the other one was they used it maybe to get their medications or to get the medications up for pharmacy. So a couple of units in secondary care started to use it to get the patient their medication. So they're using this like a prescription, and that's great. It's terrific. They go, they get their medication, they're sorted. Only the patients have been dropping them into the practices, partly because it says discharge summary up at the top. So my only ask on this is, if it's something you're doing, I'm not asking you to stop doing it, but I would ask you to ensure that the patients don't drop them in, because when they first came in, it again triggered all kinds of, what's this? Are we meant to issue these? Is this it? Is there a problem with the PDF, the portal discharge form? So just to let you know about that one. Nearly there now. Next one, Jill. Thank you. And if you don't have any questions, I'd be very surprised. So, Tom, do you want to come back in and field the questions? I can't see chat on this, by the way, if anyone's put any questions in chat.
Thanks very much. There is nothing in the chat right now, certainly. But thank you for all the hard work that you've done over the last number of years on all this, all 3 of you. And I know how much of a effort has gone into it. Anybody got any questions? Want to stick their hand up, or any particular points highlighted during that? So my question would be, given that you said early on that the phone call, pick up the phone to speak to a GP to ask for a drug is not the way to do it, but sending an OPCOM for something urgent is also not the way to do it. Things do crop up where results arrive and things need to be done. So what is the way to do it if it's not to pick up a phone and speak to you and it's not an OPCOM? And I can't do it because the patient lives in, I don't know, it's up in Blackgarry.
Well, one of the units I worked with, and this came out of, this kicked off with, it's pediatrics, and it came out of the work, talking to each other over the pandemic. So they've had people coming to the hospital to get medications, prescriptions for years. So what we did was they got blue pads, they scanned them in, and we got them the email addresses of all the pharmacies in Tayside. And recently I put that to our cardiology colleagues, And I've shared all the emails with one of the cardiologist I was engaged, working with, to say, look, you could do that. You can run a thing, set it up automatically. I'm not asking each and every consultant to know how to scan and find the emails and send them, but you could get the administrative staff to do that. Essentially, that in effect is often what the practice just does. So we get the outpatient communication, goes to the GP, creates the prescription, and I go to the desk and just get it sent to the patient's pharmacist. And the advantage of doing it is that if your admin staff could do that and you've written the prescription, it takes us out of the loop. Now, I also spoke to somebody who said, well, on that day I was working from home and that's why I did. And I said, yeah, like I do try to call people and say, how come this arose? And I said, okay, but in that situation, could you maybe call one of your colleagues? Maybe that's pushing it a bit. But I also said, look, no GP is going to turn around and not do something in the rare occasion when it's an emergency. It's the feeling that there wasn't an emergency and there were other solutions. So part of what I'm trying to do is let everybody know, A, what the other solutions are, but if they're still not possible, then the practice will sort it as they've done for years and years, because we're colleagues and we all want what's best for the patient. But yeah, that's one way, Tom. And there's others. Some departments have looked to TTOs. So considering it's something that is common, they look at it and go, oh, that could do it, say, I don't know, an antibiotic. So instead of sending off the electronic thing and saying, well, I'll get the practice, you phone them up and tell them there's an urgent request for an antibiotic, get some TTOs or something. So each unit has its own solution, but it's the conversation. And I've literally gone to places in the community to see what they do so I can find the solutions.
Yeah, and I know we have TTOs in the respiratory department because antibiotics and steroids are a very common thing to prescribe to people when they've come into the outpatient department and are unwell. It's the thing that we don't necessarily, we don't have a TTO for, or it's not when they come up to clinic, it's more that we've got some results back or they've phoned us or something has happened. But I think clearly there are solutions. I think that perhaps we in secondary care have not thought about them because it's not a very frequent thing, or whether it's that we just haven't been fed that information to a single place. So I think it's very, very valuable, Pascal, that you're focusing on this, because you can come to us with these solutions. Tom has got his hand up in the air and time is cracking on. So I want to make sure we have space for a man who knows a lot about drugs.
Hi, Tom.
Hi, Pascal. Thanks for the talk. First of all, I want to congratulate the GPs in our area for going through all the guidelines before they send patients to our clinic. Patients with resistant hypertension that are very difficult, every practice has one or two. And when they get to our clinic, you've done everything, absolutely everything. And we end up then, I know you do though, but we end up then having to prescribe medications which are not in the guidelines, and might not even have a license for hypertension. And that causes the grief, because I get a note from a pharmacist saying they can't prescribe this or I can't give it.
Yes.
And we're not going into the specifics of this, but I then fill in one of these forms that asks for that patient to get it. And then the next time this arises, the same thing happens, and you have to go through the same process again. So okay. I don't know if there's a solution to that. But,
sorry, Tom, that again, I only know a bit more about it because I've been working, as Tom Farden says, I've been working on it for a while. And I was working on a pathway that needed a medication. So myself and the people working on the pathway, we filled in the form. So essentially what you do is you let MAG, the Medicines Advisory Group, who meet every month, know that you need this medication on Tayside area formula for this indication. And it could be processed in 6 weeks, all going well. Now, there are processes. If it's an expense thing, there's another group look at the money. But the principle is, if you think that's a medicine we need to have access to, you put the form into MAG and they make a decision quickly.
Yeah, I did it once, but then it happened again with the same drug. Anyway, I think it's a general point that the patient usually needs the drug pretty quickly, and 6 weeks probably isn't reasonable. Anyway, I'm just highlighting that it can be a bit frustrating as a secondary care physician prescribing drugs off license when you can't. And I don't know what to do about it, but there we go. But it's one of the
help. No, seriously, when I said I would help, I don't mean I'll stand back and mouth off and say stuff. I'd literally sit down with you, work out the drugs you need, start getting the form process started. Scott Jemison's my colleague at MAG. He and I have worked together for other departments of medicines. And this is what strikes me, that it is there, but it's felt, well, other consultants have told me, oh, you know, the forms are too hard to fill in, or no, seriously, I mean, let's just call it what it is. It's not that you can do it in 5 minutes, but if it's important enough and it needs to be done, and once you fix it once, you fix it for all. And then it comes out to the practice, and the pharmacy look and say, yeah, that's on Tayside area formula. It's second line 4. It's what we call amber, meaning we're allowed to prescribe it. Prescription made out, job done for all of those patients.
Hooray! All right, then we'll.
You can get in touch with me.
I will do.
Thanks. There's a question on the chat from Francis Travers, who has said, can we use the communication to GP form to give an equivalent of a quick outpatient letter update if there's no med changes, or should this only be used for requests for medication changes? And brackets, thank you, I've learned a lot from this talk. So I wonder, there is, of course, the patient note form that we can fill in rather than the communication to GP. So which one would you rather us use?
Okay, thank you. Now, this is important. Okay, you're right, there are two. Please remember, we don't see the clinical note stuff, okay? The other form. And again, I only came across it when an incident arose, the individual thought, but I've told the practice, and the answer is that doesn't come to us. So the immediate communication to GP, you can use that simply to inform the practice. Now, for example, one of the first teams that started to use was dietitians, okay? It's not mainline secondary care stuff, but it really worked for them because they could just put in the little bit they needed to, bingo, done. So the answer is yes, you can. And indeed, we have a weekly newsletter that goes out to everybody in primary care. And about 3 weeks ago, I put out a reminder to practices to remind them that it's not only for prescriptions. I think somebody had, again, I don't know who's on this, but some of my colleagues out here on this thing, like they get in touch with me and say, look, I got this thing from a GP that isn't right, or they sent me this letter isn't right. And then I liaise between, and I feed back to the practices saying, no, actually, no, the secondary care were correct there. We've agreed that at GP sub. It's not only for prescriptions. It was 5 years ago, but not for the last 3-4 years.
Excellent. And just for a point of clarification, when the patient note is done, it goes onto portal, so you can see it. It's just that you don't get notified that it's there. Is that what you're saying?
Yes, and that is very important to do with other aspects of work between interface, okay? And if you want a GP to do something, we need to know, it needs to come into us to alert us, you know, so, and all of us as clinicians, it's not that great when the patient contacts you and says, Dr. So-and-so says you can look something up in portal, and that's why I've made this on this appointment. So then you spend the time trying to figure it and prepare yourself to share whatever it is. So most GPs won't go near that note on portal. They'll have no reason to. Sometimes it's to do with their admission and.
Oh, indeed. But if we use the communication to GP, it gets pushed to your docman, so it comes into your workflow. Yeah. You'll see it, and it doesn't have to have a drug on it. I think that's really useful information to us. And
some of my colleagues have asked, and it's not essential, and we'll look at it in the new clinical portal, but it does help if you say something on the lines of this is, you might say, instead of there won't be a follow-up letter, this is the communication, just something so they know that this is it. And don't kind of file it away and say, well, I'll wait and see what the detail letter says. Just without spending ages typing. I mean, I'm not asking for a long monologue as to why you're sending it, but it does help to know that that's it.
Right. Well, we've run over time, which is nice that there's been this discussion and chat, but we do have to draw things to some sort of close, mainly because I've got to go to clinic. So thank you very much to all three of you for the talk. Thanks to the audience for coming. This is a really important topic, and it's really good that to improve this communication between us, because as you said a number of times, Pascal, what we're after here is the patient is the center of all this, and what we want is the best for our patients. And being tied up in, miscommunication, it's annoying and frustrating for us, but it's more exponentially more so for the patient. Next week at Grand Rounds, the sexual health team return. Sarah Olstaff, who's been here before, it's not her first rodeo. She's going to come and talk about clap for the NHS, a post-COVID gonorrhea outbreak. So I shall leave you with that. Something to look forward to for next week. Thanks very much, everyone. Have a great end of the week and the weekend, and I'll see you again next week.
Bye, guys.